All right, wonderful. Well, I want to thank everyone for inviting me to speak today. I'm very excited, particularly because I'm speaking now to an audience primarily of experts in the field of Chiari malformations, which is a fairly new area for me. I'm an experimental psychologist by training, and my research is focused on looking at genetic variation and some specific environmental exposures on neurodevelopmental trajectories in infants and young children. So I really wanted to start out today, although ultimately I'll be talking about the rate of Chiari 1 malformation in children and mothers with depression. I wanted to talk about how we got into looking at that, because it wasn't something that we had planned on looking at per se in the outset. So I want to give you kind of the background of the research that led into this. So depression during pregnancy is clearly an important health problem. About 6 to 12% of pregnant women suffer from depression, and untreated depression is associated with multiple risks for both mothers and babies. In particular, women are at increased risk for isolation, suicide. They're less likely to get less likely to get appropriate nutrition, and more likely to engage in risky behaviors such as smoking or drug abuse. In terms of babies, infants are likely to be born earlier, to be smaller, and postpartum depression is also strongly associated with depression during pregnancy. And postpartum depression is associated with decreased maternal sensitivity and attachment, and we know that has long-term consequences for cognitive development and behavioral problems in the children. So, we have to do something about depression during pregnancy. Not treating is not an option. There is no gold standard as to the best way to treat depression during pregnancy, but there are some rubrics out there, many of which recommend treatment with a particular class of antidepressants, the selective serotonin reuptake inhibitors. Currently, over 10% of pregnant women fill prescriptions for SSRIs, a huge increase from even 10 years ago. And there's been a lot of discussion, concern and controversy in public, in patients and providers about prenatal SSRI effects on child health. We've seen conflicting results for a range of different phenotypes, and we're really lacking information on brain development. Why am I not advancing? Like to figure out. Okay. It looks like my screen froze up, so I'm going to try and take care of that for a minute.
No problem. So your screen is just freezing for a moment.
Indeed. I'll try restarting it. So I want to just briefly talk about the selective serotonin reuptake inhibitor mechanism. Quite simply, these work by blocking the reabsorption of serotonin. by targeting the serotonin transporter, thereby increasing the amount of serotonin at the synapse. Okay, so where did I leave off? Okay, so there's controversy about the impact of these on child health and development, but there's certainly theoretically plausible reasons to think that disruptions of serotonin could disrupt child development. Serotonin is a monoamine neurotransmitter derived from tryptophan, primarily found in guts, platelet, and CNS. In the mature organism, it participates in GI motility and secretion, cardiovascular regulation, circadian rhythms, perception of pain, nausea, and sexual behavior, among many other functions. Serotonin neurons are actually some of the first to arise. They're present by embryonic day 12 in the mouse, week 6 in the humans. The enterochromatin cells of the gut that are capable of producing serotonin can do so by embryonic day 15.5, so around week 8.
At the secondary analyses. So we did want to get a better sense of the mechanism that might be underlying our findings. So we looked at a few different things. One thing we did is to try and look at whether this might be a direct effect of medication exposure, is we wanted to look at the duration and the timing of exposure and how that affected the occurrence of CIM. So we split the sample into those who'd been exposed to an SSRI in all 3 trimesters versus those who'd been exposed in less than 3 trimesters. So you can see here that the longer duration of exposure does seem to be associated with increased risk compared to the shorter periods of exposure. So here, 26% compared to 0% in their matched comparisons is significant. Whereas in this group, we don't see a significant difference between the SSRI exposure in less than 3 trimesters and the matched comparison. And if you look back at Hill's criteria for causation, we usually think that a longer duration of exposure associated with the more severe effect, bumps up the level of evidence. We also looked at whether children were exposed at conception versus post-conception, based on that being a sort of proxy measure of exposure during organogenesis. And we can see here that the SSRI exposure at conception is significantly associated with an increased risk of having a Chiari-1 malformation. The post-conception exposure is also associated with an increased risk when we use our Kaplan-Mantell-Hansel statistics, but not when we use our logistic regression. So again, it looks like exposure at conception has a slightly greater risk. We were also very interested in the possibility of a genetic component. So you can see here that we split the sample based on whether the women reported a family history in their first-degree relatives of major depressive disorder or bipolar disorder. And this is really quite striking, although it's a small sample size, so I really do want to be cautious about it. But here we're seeing 45% of the sample that reported a history in maternal first-degree relatives compared to 0% in their matched comparisons. Clear the significance, very high odds ratio, although again, a big spread in the confidence interval. And in contrast, for the women who report no family history, we don't see an elevated risk here. And I think this is really interesting because the actual rate of having maternal relatives, having first-degree relatives in the moms was not different between the group that was exposed to SSRIs versus the group that simply had a history of maternal depression. So this really suggests that it's not that Chiari malformations and depression are simply riding along together in similar areas of the genome, but this would suggest a possible kind of double hit model or interaction effect where both the exposure to SSRIs or other factors associated with being treated with SSRIs is interacting with the underlying genetics. So outstanding mechanisms. Clearly the major outstanding question here is what is the underlying mechanisms? Do SSRIs directly increase risk for Chiari-1 malformations, or do other factors that differentiate women treated with SSRIs from untreated women increase the risk? So I've just talked a little bit about genetics, which would be one clearly interesting factor. Another one would certainly be the severity of the depressive illness itself. And unfortunately, we don't have a good direct measure of that in these women, and that's something that really needs to be looked at in future research. So given that, we did go back into the literature and try and look at, what is the role of serotonin in craniofacial development? Is it theoretically plausible that SSRIs would increase risk for Chiari 1 malformations? Is it plausible that, some other feature associated with depression would be involved? So this is just kind of a summary of some of our thought processes, and I'm very interested to hear what you all think from the perspective of, being experts in Chiari 1 malformations. So serotonin certainly does play a role in craniofacial development. It regulates mouse cranial neural crest migration. You can see that here in this figure from Moisowicz and Lauder back in 1995. Mesenchymal differentiation, as well as expression of growth factors and molecules of the cartilage matrix. This is a figure here from Lambert and Lauder showing serotonin's impact on IGF-1 levels. And it also promotes the proliferation of osteoblast precursors. So potentially has a role in ossification. There are some studies of SSRIs in craniofacial development, showing that they disrupt epithelial and mesenchymal interactions. This is a fairly old study from Shui et al., showing an impact of fluoxetine here on the developing embryo. These are embryo cultures, so you can see a lack of forebrain expansion and underdeveloped maxilla, as well as other changes between the two. It also inhibits osteoblast formation and function, reduces cell viability, and induces apoptosis in vitro. Quite a recent study from Hodge showing that. Now, it's important to keep in mind that the doses here are probably quite high compared to what's happening in clinic. The dose here used in it's the same dose in this outcome here in the earlier study, which would actually have been fatal in the mums if they were given this dosage, although Hodge points out that these may actually accumulate in bone, so you end up with higher doses there. Okay, so it's theoretically possible that SSRIs might be involved in craniofacial malformations, but there are a number of alternative potential mechanisms that we've been trying to think about as well. Certainly, depression is associated with neuroendocrine disturbances, dysregulation of the HPA axis, changes in levels of leptin and ghrelin. Some subset of moms have an inflammatory phenotype, so higher levels of circulating cytokines. We see a variety of metabolic disturbances, obesity, metabolic syndrome, diabetes. We did obviously try to control for that in this analysis. I should say that we did rerun our logistic regressions, including those factors that were different between the two groups. So gestational age of birth, birth length, hypertension, BMI, and still the SSRI was the only significant predictor. Unfortunately, there are no studies really looking in humans specifically at SSRI exposure and craniofacial development. There are a number of studies looking at SSRI impacts on growth, as well as untreated maternal depression, but the results are fairly inconsistent across studies. The largest study to date, which was carried out by El Maroon and colleagues using Generation R cohort, which is a really fantastic cohort, showed that SSRI exposure was associated with smaller head circumference at birth, as well as reduced growth of the fetal head with sparing of the body. In contrast, untreated depression was associated with a reduction in total body growth. And you can see their results there. So that's one outstanding question. Outstanding question 2, what is the long-term functional outcome in this group of kids? So, and this is another area where I'm very interested to hear your perspective, but there are appears to still be a lot of debate about what is the natural history of incidental CIEM identified in early life, and our sample is particularly unusual, being, infants and being a, population study, so these kids were having MRIs for reasons completely unrelated to any symptoms. And then, of course, will the SSRI-exposed children with CIEM actually follow the same course as other individuals? Just kind of finished up with kind of the strengths of the study. We included both an SSRI-exposed group and a group of non-SSRI-exposed children of mothers with a history of depression. We had pretty detailed exposure data, the blinded assessment of the Chiari 1 malformation, the use of propensity matching to minimize differences between the exposed children and their comparisons. Exit out there. On the other hand, there are clearly some limitations. It's a relatively small sample size. We don't have direct measures of symptom severity. And of course, the hypothesis being tested was formulated during data acquisition, not something that we expected going in. So clearly replication is needed, as well as additional research to look at these underlying mechanisms. And I will, I had one other slide in a previous version that has gone missing. But I did also want to talk about the clinical implications of the study. And at this point in time, we would discourage clinicians from changing their prescribing practices based on the results until there is replication and a better understanding of the mechanism. But I do think, there's often a long period of time to get a diagnosis of Chiari 1 malformation. So I think it could be quite helpful for families in this situation to be aware of that going in as well. So that's kind of the clinical picture. And I will finish up by thanking the various people who worked with me on this study through the UNC Center for Women's Mood Disorders, as well as the Schizophrenia Research Center, which ran those other 2 large studies we were talking about, especially my co-authors, Samantha Brody, Keith Smith, Kenneth Lurie, Bob Hamer, Sandra Wilson, and John Gilmore, as well as various people who helped us in the image analysis lab. We didn't have to do a lot of sophisticated processing on these, but we did have to pull back up all the original DICOM images for our neuroradiologists to look at. To thank the people who did the recruitment and the early brain development studies, as well as our funders through the National Institutes of Health and the Foundation of Hope for the treatment, for research and treatment of mental illness here in North Carolina.
Okay, thank you so much, Rebecca. Before we get into questions, I'm just wondering, does anyone want to see any slides that were difficult to hear the voice? We should go back to any of those. There's 2 or 3 in there especially that were hard to hear.
Sure. Which ones were you thinking of, Bryn?
For me, I think it was okay for me, but I'm wondering if anyone else was wondering. Okay, then I guess we'll just go ahead and take questions.
Rebecca, this is Rick Labuda. Thank you so much for this presentation. And I apologize if I missed this during the talk. Was there an indication of whether the treatment for these women were successful with the SSRIs?
That's a great question. And as I said before, we didn't have any direct measures of symptom severity, which would allow us to assess that. But I think that is important because there's a lot of interest, again, in a kind of double hit model where you have both treatment and active symptoms, because certainly pregnancy changes the metabolism of these medications. And sometimes, women or their providers will reduce doses during pregnancy because of concerns. Yeah, it would be very interesting to know more about that.
Well, do you think the fact that there was the link with the 3-trimester exposure, does that indicate in any way, and I'm not at all familiar with how long people are generally given these SSRIs, but does that indicate that they did have some type of depression that was at least at some level resistant to that treatment, since they carried it through for 40 weeks or whatever?
Yeah, so most of the women in the 3-trimester exposure group would have been on probably throughout the pregnancy. So these are women who had a history of depression or severe postpartum depression who elected to continue on their dose throughout because they were well controlled.
Okay. Okay. And have you considered imaging the mothers at all?
That would be really interesting because, of course, one of the things we're missing is we don't know if the parents, not just the mothers, but the fathers, have Chiari malformations themselves. And I would love to have somebody to do that because it would be very interesting to see whether this is, you know, an interaction effect with some genetic predisposition to Chiari,
right,
or whether, you know, it really is, you know, idiopathic in these kids.
Right. Right. Now, is there another way to get at this? Is there anything predictable, any type of predictable hypothesis that you could make, predictable testable hypothesis that you could make regarding that long exposure that you would expect to see in these children, if somehow the drug were not, you know, cleanly processed or whatever? In other words, it had a developmental impact. Are there other manifestations of that could be looked for?
Are you thinking about other phenotypes?
Yeah, I guess. I mean, not necessarily, you know, related to Chiari, but say that clearly, you know, in this subset of people, for whatever reason, the exposure to SSRIs had, you know, a negative effect or presumed negative effect. One aspect of that was the tonsillar herniation. You know, are there other ones that are a little more obvious that wouldn't have necessarily been a surprise to potentially look for in these kids?
Yeah, that's interesting because you don't see a lot of the published literature breaking down based on the trimester or the length of exposure. There's a little bit of that. So you would have seen, let me go back. Not that one. So, you know, we haven't broken this down into the longer exposure versus the shorter exposure, but certainly we did see, you know, reduced age at birth and reduced birth length. So we could go back in and look at whether that is also different between, based on the duration of exposure.
I see. Well, can you leave that up for a second? I didn't see those BMIs before. So in the Chiari cases, were the mothers a higher BMI or not?
So we did do, in addition to running the logistic regression with these variables added back in, we did look at every kid in these 3 studies who had been flagged as having a Chiari-1 malformation and who had not been exposed to SSRIs, and compared them to all the other kids in the sample. And in fact, those the Chiari-1s in that set did not have moms with higher BMI.
Okay. Okay.
They did not have earlier birth. They didn't have shorter birth lengths. They didn't have more hypertension. They looked, in fact, they looked healthier than this sample.
Sure. And there's no indication yet of any symptomatology associated with these children with tonsillar descent, right?
Right. So at this time, we're not aware of any who've developed active symptoms. Another thing we would like to do is, you know, get back in now that these kids are getting older to see if we could rescan and do some symptom measures just to confirm that in a more focused way.
Okay. Well, I think it's just tremendous work. I think it's very exciting, and I'm very glad that you'll be able to make it to our larger research conference in November. I think it'll generate a tremendous amount of discussion, and I for one, have been encouraging Bryn and Frank Loth and Phil Allen, who's a psychologist associated with our center, to you know, pursue this line of research with you and see what types of you know, if you're open, whether there's some opportunities for collaboration moving forward with this as a basis.
Yeah, I mean, we'd be very interested in developing this further. We've been thinking of a few things. I'd love to talk to you all. One thing we're thinking about, not just for the Chiari malformations, we've got some other interesting brain development stuff, but we're talking about potentially trying to get a rhesus monkey model of prenatal SSRI exposure. And I don't know whether we'd expect any of the Chiari-1 malformation-related stuff to recapitulate in the monkey, but I think it would be really interesting to think about what you would look for in that kind of model.
Sure.
Yeah,
Sure.
Rebecca,
And we do have a research, right? You asked for our opinions on certain things. We do. There's a guy that has been doing work for us for several years, a developmental molecular biologist over in the UK, who is focused in on the role of the neural crest cells in the development of the cranial abnormalities associated with Chiari. And specifically, he believes that the clivus, the cells at various points in development, around, I think, some very early, but also another wave around 10 to 13 years of age, are not fading properly to bone, and some are remaining cartilage. So it is interesting that you pointed out that there's at least one article in the literature that indicates the serotonin can affect the neural crest kind of pathway in the skull development.
That's fascinating, because that really was the struggle for us, was trying to figure out which aspects that serotonin had been involved with would really be most relevant to Chiari, given that, kind of the pathophysiology there is still, it's still not fully understood.
Right, right. Were there any other bony abnormalities that you looked for, such as retroflex odontoid or assimilation of the atlas and the axis, or flattening of the skull base? Any? Or were those?
We only looked at these three. So if there are other things that would be interesting to look at, I'm certainly open to knowing those.
Okay, great.
Yeah, Rebecca, this is Bryn here. Yeah, we're doing many studies looking at different morphometrics as indicators of Chiari, and that's one thing we'd be very interested at looking at, either with you or teaching you or your team what metrics we're doing now. We could do them for you, or we could teach you what those are. Yeah, so I don't know if you've seen a paper by Ansani or Bizu in 2013. It's a Chiari morphometric paper.
I think I have.
It's actually the guy who was on Alphonse Macaya, who was on the call. He actually left the meeting a little bit early. It's his group in Spain, and they did a large study with 100 Chiari patients, doing 19 different morphometrics in the mid-sagittal plane. And we'd be very interested to, look at those in this patient, in your subjects here. Well, I shouldn't say patients, but people. Yeah. So
well, I think we'd be very interested in that.
Yeah, well, I can email you about it afterwards. I don't want to take too many questions away from other people, but I have one question. So if the SSRI exposure is contributing to risk for Chiari, you might hypothesize before the SSRIs were used, then you'd have less Chiari, right? And I'm wondering, what year was that? When did people start using those SSRIs? And I don't know if there's any way to.
That's a tough one. So yeah, the rate of the usage of SSRIs has really increased. So that greater than 10% rate was from a 2007 study. So it's probably even higher now. Back in 2000, it was more like 5% of the population. So yeah, there's definitely a strong time trend. I think the difficulty is so many other exposures are changing at the same time. How do you actually, figure out which ones are causal and which are just incidental? It's interesting. There's also a fair amount of, again, it's a lot of confounding variables. I mean, there's variation across countries in how many people use these. So I mentioned this Generation R cohort, which is over in Europe, and their SSRI use rates during pregnancy are about 2%.
Oh, okay.
So I don't know if you could get something out from kind of comparing across countries that way.
Yeah, so
I certainly don't know if
it's going to be complicated by
yeah.
access to imaging, right? It's going to be complicated by how readily patients are sent for an MRI too.
Exactly.
So I want to give other people a chance to ask questions.
I have one more question, Brent.
Okay.
I don't mean to monopolize, but I'm sorry. I find this very, very interesting. So, Rebecca, is it meaningful at all to check the serotonin levels of the infants and young children?
I think, yes, I think that would be very interesting. So people have done it looking at some other behavioral outcomes. There's this sort of, people once debated whether it was serotonin withdrawal versus a sort of hyperserotonemia in these kids. Some of them have a kind of an adaptation syndrome, which is transient, but maybe a week or two after birth. So certainly people were looking at the serotonin levels in the kids related to that. So I think it would be, for a larger study, I think actually monitoring both mom's levels during pregnancy and the levels of the kid after birth would be very interesting. I don't know how well we can extrapolate from what we see at birth in terms of the fetus's exposure earlier on, but.
Right. Okay, I'll stop monopolizing now, Brett.
No problem. Okay, so let's have some other people ask some questions. Frank, I think you have the mic. Go ahead.
Phil Allen has a question.
Rebecca? Rebecca, can you hear?
I can hear.
This is Phil Allen, and I'm wondering if your results could not be explained by lower serotonin levels in the mothers that were taking SSRIs. For example, you showed a huge effect for a family history, which might be a genetic predisposition to low serotonin levels that we know depressed people tend to have. And the mothers that were on SSRIs probably had more severe depression than the mothers that were depressed but were not on SSRIs, right?
Yes.
So are you sure that it's not actually an SSRI effect, but a low serotonin effect?
That is absolutely great idea, particularly given that interest in the early maternal component.
Yeah. Mm-hmm. Because we know actually that serotonin has an effect on the neural tube development as well as the skull development, right?
Yes.
In that PNAS paper with mice, they were arguing it actually had an effect on neural tube development. So
yes,
I'm wondering if it makes sense to then correlate serotonin levels in adult Chiari type 1 patients with the severity of their symptoms then maybe.
Oh, that's a really interesting idea. I wonder though if it's about the maternal level, how strong would the correlation between the maternal and the offspring level be?
But I think if my hypothesis is anything close to correct, that the maternal levels of serotonin have modulated genetically and epigenetically the levels of serotonin in the offspring. And that's why you're getting that family history effect.
Yeah, that's really fascinating.
Yeah. Well, it's just food for thought. It just looked like it was a parsimonious way to account for your data.
No, I like that a great deal. And we definitely want to pursue this, in a larger sample where we can look at maternal levels, look at the kids' levels, get indices of these other potential mechanisms like HPA axis reactivity.
So would you recommend looking at either ACTH or cortisol as well for the HPA axis?
I mean, I think it's a theoretical possibility.
Okay. in the
But again,
mother.
it'd be great to hear from the Chiari folks as to whether, which hormone systems they think are most likely to be involved.
Well, we tend not to be endocrinologists. The neurosurgeons don't really look too much at neurotransmitters. Biological psychiatrists would probably be interested in that. But with the link of serotonin to the HPA axis that you were mentioning, and digestion and stuff, and stress, that sounds very interesting.
It is. And one of the other thing is there's so much overlap and crosstalk between the different systems, too.
Unmuted.
So are there other people with questions? I had another question. I think you mentioned that the SSRI can accumulate in the bone.
That's what Hodges' group was claiming, but that's a little outside of my area of expertise, so I'm trusting him on that.
Yeah. So would it be in all bones, or I mean, which would it be in certain ones, or?
Yeah, I don't know if anyone's looked at whether that would vary across. So he was saying that there's sort of a magnitude higher level if you looked at accumulation in the bone. But of course, I don't know, it seems to me like that would be a global effect as opposed to a site-specific effect. And there hasn't been a lot of research looking at, skeletal development in kids, and fetuses exposed to SSRIs. There's been talk about kids taking SSRIs and how that impacts skeletal development, as well as in sort of postmenopausal women in relation to osteoporosis. So people are thinking about serotonin in bone. There's one study of SSRI-exposed, prenatal SSRI-exposed kids, looked at the tibial bone density and didn't see any difference, but that was the only thing they looked at.
I'm wondering, there's a member of our group, Leah Shriver, actually maybe she has a question on this, but I'm wondering if she's able to detect these drugs, for example, using her metabolomics. That's possible.
Yeah, I would imagine it would be.
Am I unmuted?
Yes.
Yeah, you can see both the drugs and you can see serotonin. So those are both detectable by mass spectrometry.
So in the CSF,
in fact, we see serotonin all the time. It ionizes really well.
Okay, so does anyone else have questions?
I actually have two questions.
Okay.
And I might have missed this, but for your matched controls for the women with depression, were they just completely untreated, or were they taking other drugs to treat depression?
Okay, so the cohort of moms who had depression but were not receiving SSI were not receiving any psychoactive drugs.
So did you look at a group of women with depression that were treated with another type of antidepressant as well?
That we did not look at, and only because our numbers were pretty small when it came to women who were receiving other classes. I will say, and we didn't put this in the paper, but I have to look back at the exact details. So there were a couple women in these in the high-risk study who did not qualify as either cases or controls for this study, but who did have Ssris Chiari malformations. And these were moms with schizophrenia or bipolar disorder who were on a variety of other things like lithium and risperidol, often with multiple pharmacotherapy. And we thought they were sort of interesting, but we didn't have enough to really look at them.
And I'm just curious with, I mean, I don't know if this data could even be accessed, but they must have done tox studies for the initial approval of SSRIs. And I'm just